right. Hello, everybody. Dr. Rayford from Vet Triage, October 10th, 9:13 a.m. Pacific time. I'm in a different location today. I'm at the clinic helping a friend out in Las Vegas. So it may be a bit echoey, and I don't know how the reception will hold up or the internet will hold up. So we'll see. But we'll move on here to JAVMA. This is JAVMA May 15, 2015. And we're talking about this article, Effect of Cardiac and Respiratory Cycles on Vertebral Heart Score Measured on Fluoroscopic Images of Healthy Dogs. So for those who don't know about the Vertebral Heart Score, you can literally Google it and see what it's like, how the measurements are taken by doctors and radiologists and cardiologists. But we're going to go through this assuming that you know how to measure a vertebral heart score and what that looks like. Otherwise, pause it, look that up real quick, and then we'll come back to this. This will be a pretty deep paper as well. These cardiac papers just have a lot. So we'll jump right into it. This is Dr. Olive and a bunch of other doctors from University of Montreal. The objective is to assess the variability in vertebral heart score measurement induced by cardiac and respiratory cycles in dogs. Dogs underwent fluoroscopic examination. The vertebral heart score was measured at end tidal inspiration and end tidal expiration during end systole and end diastole in left and right lateral recumbency. So right off the bat, you can see how complex this paper is going to get because they're looking at dogs in fluoroscopy that are in the breathing cycle of end tidal inspiration. So that's the end of when they're inhaling. End tidal expiration, which is the end of the expiring when they're breathing out. And they're measuring that during both end systole, so at the end of the cardiac contraction phase, and they're looking at it at end diastole, which is the end point of when the heart fills up with blood. And then finally, they're doing this both in left and right lateral recumbency. So the dogs are either on their left side down or right side down on the fluoroscopy table when they're doing this. So they have to compare all these different permutations. So this will get a bit complex because of all the terminology that we're going to use here. What the results were, they found that the mean vertebral heart score for each combination of respiratory and cardiac cycle was larger on images obtained in right lateral versus left lateral recumbency. So that's interesting. For each combination of breathing and heart cycle, when you have the dogs in right lateral, right side down, the vertebral heart score is larger than when compared to left lateral recumbency. The greatest differences were observed between vertebral heart scores measured in the diastolic inspiratory phase for right and left lateral recumbency. So the greatest difference were observed between vertebral heart scores measured in the diastolic inspiratory phase. So when the heart is maximum blood capacity during inhalation of the patient, that's the biggest differences seen when compared for right and left lateral recumbency. Right lateral recumbency had a vertebral heart score 10.59, whereas left lateral recumbency had a vertebral heart score of 10.35. So about a 0.24 difference in measurements when you're looking at that. And by the way, the units for vertebral heart score are vertebral units, VU. Then when you looked at systolic expiratory phase in right and lateral recumbency, there was a difference there. Right lateral recumbency during systolic expiratory phase was 10.11 and left lateral recumbency was 9.92. So that is a 19-point difference during the maximum contraction of the heart when the patient is breathing in. The combination of respiratory and cardiac cycles induced a maximum difference in vertebral heart score of up to 0.97 and 1.11 in the inspiratory and expiratory phases respectively. So when you combine the respiratory and cardiac cycles when you combine them, it induced a maximum vertebral heart score difference of 0.97 during inhalation and 1.11 during expiration. The conclusion of the paper is consistently collecting radiographs at end inspiratory tidal volume may help limit vertebral heart score variability attributable to the respiratory cycle. So if you're going to take radiographs to measure vertebral heart score, you want to ideally plan collecting the radiographs when the patient is at its maximum inspiration, so inhaling during the respiratory cycle. That will give you the less amount of variability between vertebral heart score measurements. All right. And the reason for that, for those who don't know, is you don't know at what phase the cardiac cycle is while you're taking the radiographs, right? You're not listening to the dog's chest while you're taking the radiograph, and the heart beats so fast, there's no way to realistically do that. However, you can try and plan collecting radiographs during the breathing phase of the dog. You can watch them on the radiograph table, the radiology table, and see, okay, this dog is inhaling. Let's click the button to get the x-ray. So now let's start with introduction. The expected vertebral heart score was originally calculated in studies with dogs in with right lateral projections. And they had different canine breeds. They found that on average, this score was 9.7 with a standard deviation of 0.5 vertebral units. Later, they started doing breed-specific vertebral heart scores, with most ranges being larger than that of the 9.7 study. So they end up having a cutoff of 10.5 or 10.7 vertebral units when you look at medium-sized dogs or mixed breed dogs. The vertebral heart score is a semi-quantitative assessment of the cardiac silhouette, so how big is the heart on radiographs, with minimum reading variability amongst observers of different levels of experience, meaning that the vertebral heart score is pretty easy to do regardless of how experienced you are as a clinician. The vertebral heart score is closely related to the severity of cardiomegaly, which is enlarged heart, as assessed radiographically on the basis of multiple morphologic parameters or via ultrasound. So when they look at the vertebral heart score, the size of the heart on radiographs as compared to other morphologic parameters or with ultrasound examination of the heart, they found the vertebral heart score is pretty accurate. The vertebral heart score, however, has only moderate sensitivity and specificity, with 10.7 being used as the cutoff. So this limits the use of vertebral heart score when you have an ambiguous case. So 10.7 is your cutoff in the majority of cases here. The vertebral heart score also is more accurate for detection of eccentric cardiac size or abnormalities rather than concentric. So eccentric is the heart is eccentric; it's getting bigger because of heart disease. Concentric, the overall heart size is the same, but the heart muscles are getting thicker, and so you don't see that enlargement of the heart. The effect on the cardiac cycle on the cardiac silhouette size and shape has already been assessed in cats by using a manually synchronized radiographic technique following electrocardiogram recordings. So in cats, they knew that the cardiac cycle affects the size of the heart. So in this study, they had 14 healthy beagles between January 2012 and 2013. They did this study in the University of Montreal. During ultrasound of the heart, the animals were positioned in left lateral recumbency with standardized views of right peristernal, left apical, and subcostal. Those are for folks who are watching this that are familiar with those angles. Then they did thoracic fluoroscopic loops, first in right lateral recumbency, then left lateral recumbency. They measured the vertebral heart score. In brief, if I have to explain how to measure it, you take the long axis of the cardiac silhouette, so from the heart base, the heart apex, you start at the ventral border of the carina, which is where the trachea ends and branches off into the bronchi. So you measure from that point, the ventral border of the carina, and you go down to the cardiac apex. Then the cardiac short axis is measured perpendicular to the long ones. That creates a long axis when you go from carina to apex. Then you have to go perpendicular to that lengthwise, or widthwise rather, starting just ventral to the caudal vena cava. Both measurements are scaled to a number of thoracic vertebra, starting at the cranial aspect of T4 vertebral body. All right, so with results. It's going to get a bit messy, so just try to pause it if you need to, but this is going to get a bit messy. Diastolic vertebral heart scores were greater than systolic vertebral heart scores at the same respiratory cycle in both left and right lateral recumbency. So when the heart is at maximum filling, the score is higher than when it's at contraction, which makes sense, right? All combinations of cardiac and respiratory phase vertebral heart score measurements were larger on right lateral images compared to left lateral. So when the dog's on the right side, the score is higher than when the dog is on the left side. I'm just looking to see here what's important for us. During inspiratory systolic vertebral heart scores measurements, they were found to be greater than expiratory systolic vertebral heart score measurements. So when the dog is breathing and the heart is at maximum contraction, those values were higher than when the dog was breathing outward, expiring, and the heart was contracting. The mean difference between systolic and diastolic vertebral heart scores was higher for when the dog is breathing out than when the dog is breathing in. When the dog was breathing in, the greatest mean difference in vertebral heart score between systolic and diastolic phases was calculated at 0.97 vertebral units. So almost a full point difference. During expiration, this difference is 1.11. The overall systolic to diastolic vertebral heart score mean difference was 0.36, and overall inspiratory to expiratory was 0.1. So here's a chart depicting that for those who want to see it. There it is. Okay. The mean difference in heart score between contraction and relaxation phases was lower when the dog was breathing in versus breathing out in left lateral recumbency. So when the dog is on the left side, the score between heart contraction and dilation is lower for when the dog is breathing in versus when it's breathing out. And then this is showing, if no one's ever seen fluoroscopy before, this is what fluoroscopy looks like. It's basically radiographs, x-rays in motion. And then here's another chart with measurements for those who want to pause it and look at that. There you go. The mean difference in vertebral heart score between when the dog is breathing in and breathing out was also greater for when the heart was contracting than when the heart was relaxing in left lateral recumbency, not right lateral recumbency. Okay, discussion. You can control the timing of the thoracic radiograph based on breathing, but not based on cardiac cycle. We had mentioned that before. Overall, the cardiac cycle impacts the vertebral heart score. There's a mean difference between when the heart is at maximum contraction versus maximum dilation. That difference is 0.29 vertebral units. And that's occurring at the end tidal inspiration. When the dog is breathing in, just before about to start breathing out, that difference is 0.29. This implies that a vertebral heart score difference of almost 1 vertebral unit on two sets of radiographs for the same dog may be attributable to the effect of cardiac cycles. When you look at the standard deviation difference, which is 0.34, then you can have almost a 1 point difference comparing vertebral heart scores in the same dog. The mean difference between systolic and diastolic heart scores were higher for when they're breathing out versus breathing in. So you want to take radiographs at the end tidal inspiration. When the dog is breathing in the most, that's when you want to collect your radiographs. Okay, and then 8.3% of dogs may have an erroneous vertebral heart score, but most of these dogs, it's not too bad. It's pretty accurate, as long as you plan your radiographs that way. In all phases of the cardiac and respiratory cycle, the score was greater in right lateral recumbency than in left lateral recumbency by 0.2 vertebral units. In previous studies, they found that there were higher vertebral heart scores on right lateral projection versus left lateral projection in beagles and in whippets and other breeds. It is well known that the cardiac silhouette has a different shape on a right lateral versus left lateral radiograph. And the effect of this magnification may also be greater on images obtained in right lateral recumbency because of the left intrathoracic position of the heart. Systolic vertebral heart score was higher than on inspiratory than expiratory. And they do go through a variety of different reasons, but essentially when the lungs are expanding and contracting, that affects the blood flow in the vasculature of the lungs, of the vena cava, and so forth, and also affects the phases of cardiac cycle. We won't go into, well, we might as well go into all that. Let's do it. Why not? Some of you might care. Okay, so there we want to look at why would it be that the systolic heart score is higher on inspiratory than expiratory? Why is it higher when the dog is breathing in than breathing out? Increasing the depth of respiration promotes venous return and enhances cardiac output. Respiratory activity affects venous return through changes in right atrial pressure. Increasing the right atrial pressure impedes venous return and vice versa. Respiratory activity can also affect venous return either directly by vena cava compression or indirectly by changing cardiac preload. Pressures in the right atrium and thoracic vena cava are very dependent on intrapleural pressure. During inspiration, the thoracic wall expands, the diaphragm moves caudally. This causes the intrapleural pressure to become more negative, which leads to expansion of the lungs, cardiac chamber, and thoracic, cranial, and caudal vena cava. This expansion causes intravascular and right atrial pressure to decrease, leading to a cardiac chamber expansion and an increase in cardiac preload, stroke volume through the Frank-Starling mechanism. During expiration, the opposite occurs. All right, we're almost done here. The left side of the heart responds differently to the respiratory cycle than does the right side. During inspiration, expansion of the lungs and pulmonary tissues causes pulmonary blood flow to increase, which causes a decrease in blood flow from lungs to left atrium. So the left ventricular filling actually decreases during inspiration. In contrast, during expiration, lung deflation causes blood flow to increase from the lungs to the left atrium, which increases left ventricular filling. The net effect of increased rate and depth of respiration is an increase in left ventricular stroke volume and cardiac output. Non-typical respiratory activities, such as application of positive pressure ventilation, impedes and therefore reduces venous return and cardiac output, which explains why, if you have a dog under anesthesia, increasing manual inflation decreases vertebral heart score by 0.24 vertebral units. And then finally, the difference between vertebral heart score in systole and diastole is greater with expiration versus inspiration when they're in left lateral recumbency. This is explained by slightly negative pressure present at the beginning of inspiration, which is approximately negative 5 centimeters of water, which is the amount of negative intrathoracic pressure, required to hold the lungs open. The previously described expansion of the chest wall during normal inspiration causes a more negative pressure, which is approximately negative 7.5 centimeters of water, which causes alteration in the cardiac chamber geometry, as well as transient inspiratory pooling of blood in the lungs. This is a suction effect. Results of a recent MRI revealed that inspiration results in a transient increase in right ventricular volume and a reciprocal decrease in left ventricular volume. So for those who need to hear that again, just rewind this because there's a lot going on there. The vertebral heart score, they end this by saying the vertebral heart score remains dependent on individual observer selection of reference points and transformation of vertebral units. The intra-observer variability, so that's the availability, the variability between different observers, is typically lower than when you compare the measurements between the same individual. And it was estimated between 0.6 and 0.8 vertebral units. So who's measuring the score determines how accurate the score is going to be or how much variability there is. But when you have multiple doctors looking at measuring the score, the variability decreases versus having the same doctor look at the scores. So that's it for that paper. Again, very complex. For those who need to rewatch this multiple times, go ahead and do it. But at the end of the day, to consistently taking radiographs at the maximum breathing in will help limit the variability of the vertebral heart score. My only issue with the paper really is that there's only 14 dogs. It'd be great if there were more dogs, but I presume that statistically speaking, because they were able to apply stats to this, that didn't really matter. All right, I hope that helps folks out. Hopefully we're going to have an easier paper tomorrow. Thanks so much for watching on the playback, and we'll see you then. Bye.